we would like to focus more on the, what is osteomyelitis, its clinical importance, its pathogenesis, how to approach a case of osteomyelitis including laboratory investigation, what are the imaging features, and what are the basic principles of management, right? And at the end I will show you some cases, to previously I have talked about osteomyelitis in great depth, I guess. So it is basically inflammation of the bone and all the components of bone including the medullary cavity. So it could be localized to a single portion, or it could involve any part of the bone including marrow, cortex, periosteum, and also the surrounding soft tissues. So its incidence is widely varied, but in general it is increasing in incidence. The common age groups are: in children we see the hematogenous osteomyelitis, in the middle-aged adults we see most commonly diabetic foot, that is a foot osteomyelitis, and it is gradually increasing in incidence, that is post-traumatic or post-surgical osteomyelitis. So in brief, the classification is like we can classify depending on the duration of symptom. It could be acute if the symptoms is less than 2 weeks. It could be subacute, symptoms is 2 to 4 weeks, or it could be a chronic osteomyelitis that the symptoms or signs are, or the infection is present for more than 4 weeks. Depending on the spread of mechanism, it could be hematogenous, it could be exogenous. That is, it is infection is coming from the outside environment following like trauma, open fractures, or it could be contiguous from a nearby source. And depending on the host response, it could be pyogenic inflammation, the pyogenic organisms like Staph aureus or Streptococcus. It could be because of some low grade virulent organisms, okay, like the fungal osteomyelitis, Staphylococcus epidermidis, or maybe tubercular osteomyelitis. So the hematogenous group osteomyelitis we see in children, in patients, or in individuals who are using IV drugs. The exogenous group we see in open fractures following some orthopedic procedures like implants, or some nearby source like contiguous ulcers and all this. And the risk factors are, we usually see in patients who are at high risk, like having diabetes mellitus, immunosuppressions, patients having malnutrition, or who are using any kind of immunomodulators like steroid and etc. And as I told, the non-pyogenic group we see in patients who are infected with tuberculosis or fungal infections, or with atypical mycobacteria. So the acute hematogenous osteomyelitis, it is the most common form. It is usually seen in children. It has a bimodal age distributions in children younger than 2 years, or in children between 8 to 12 years. So the most common site of involvement is the metaphysis of a growing long bone. This is the most common site of hematogenous seeding of the organism. And I also discussed with you previously, depending on the blood supply and anatomical structure of the bone, the presentations, the spread of infections vary. Okay. So how does it matter? Okay, so before we go into some blood supply, why this metaphysis is involved? This is a common questions in your viva, maybe theory, or in PG examinations. So in metaphysis, we see this hairpin loop. Okay, so that means and also supplied by the end arteries. So that means the blood flow is sluggish over there. So the organisms get higher, there is a higher risk, and the risk of seeding of the organism is more in this end, because it is supplied by the hairpin bend and end arteries. And also this is the physis. So this is the growing part of the bone. So what happens, the bone turnover and also the immature cells, degenerative cartilage cells, they are populated over this region. So these cells, and because of this high turnover rate, this area is prone to infections, infectious bacterial seeding. And also Another important factor is this area there is relative lack of phagocytosis. Okay, so the organisms can potentially survive in this region and can thrive, and this region also is more prone to trauma, and also the blood vessels have a single endothelial lining. So these are all the risk factors that impart higher risk of infection in this region in hematogenous osteomyelitis. So in short, what is the pathogenesis? After the bacterial seeding, what happens? There is inflammation. Okay, so inflammation, there is a the cells are there is also inflammation. It leads to there is a edema which lead to local ischemia. Okay, it compresses the blood vessels and can cause ischemic necrosis of the cells over this region. Okay, so all the procedures like inflammation, edema, and like degenerative cells, they increase the intramedullary pressure over this region. They can propagate the ischemic process, and all this subsequently lead to subperiosteal abscess. This abscess breakouts of the cortex, it lifts the periosteum and cause the bone destructions and subsequently periosteal reactions, reactive new bone formations. So this is a vicious cycle from the bacterial seeding to inflammation, ischemia, subperiosteal abscess formations, and the spread of the abscess. So this is like in the metaphysis, there is a bacterial seeding, it subsequently grows, there is abscess formations, it's break out of the cortex, it comes out, it lifts the periosteum, and once it's lift the periosteum, there is reactive formations. The bone tries to contain the infections, so we get periosteal reactions and reactive new bone formation. And depending on the blood supply, in children younger than 2 years, I have discussed with you previously, in children younger than 2 years, we have, in general, we have to remind that the feces, the part of the feces, this is basically, it prevents spread of the infection. Okay, so what happens? But in children younger than 2 years, the blood vessels, they cross the feces. So any inflammation or infection that is present in the metaphysis can cross the feces and can go into the epiphysis. But in children more than 2 years, these blood vessels are not there. So the feces acts as a barrier to the spread of the metaphyseal infection. So in less than 18 months, less than 2 years, you see the feces, this is a part of the feces, they basically prevent spread of the infection. But in less than 2 years, the blood vessels, they have a common blood supply. So infection can go over there and spread into the joint. But in 2 years till adulthood, till 16 years or 18 years, there is they have a separate blood supply. So the infection, there is less chance of spread of infection. And in adults, once the growth is complete, the feces is absent. So again, the infection can spread from any part of the bone to the epiphyseal part and subsequently into the joint. So septic arthritis is common in patients in children in less than 2 years and also in adults because of this mechanism. So hip joint is the most commonly involved joint in children. And this picture you have to note down, you have to understand the concepts that in some joints, this is the feces, in some joints what happens, the capsule is attached below the feces, okay, near the metaphysis. So basically this metaphyseal part is inside the joint. What are those areas? These are the areas: proximal humerus, radial neck, distal fibula. These in this part, they are basically feces is interarticular. So any metaphyseal infection can cause septic arthritis. But in other regions, see, normally the capsule, this blue is the capsule, they attach above the feces. Okay, so the metaphyseal part is outside the joint. So these regions are protected from spread of from septic arthritis. What are the most common organisms? We have Staph aureus, Streptococcus, Gram-negative organisms are more common. Haemophilus influenzae. This organism was common in patients in 6 months to 4 years, and in individuals who are having IV drugs, Pseudomonas is the common organism. And what are the special circumstances? In patients with sickle cell anemia, Salmonella osteomyelitis is common. And what are the special characteristics? This osteomyelitis involves the diaphysis. Instead of metaphysis, they involve the diaphysis. Okay. In diabetic foot, this is a polymicrobial in nature. They have gram-positive, gram-negative anaerobes. In patients who are immunocompromised, they have a infection with some low virulent organisms or some atypical organisms like fungi, atypical mycobacteria, etc. Now, how do you approach? If a patient comes to you, how do you assess the patients? How do you plan to investigate? So, your approach starts with the history. You first get the proper history, the duration of the symptoms, the nature of symptoms, the gravity, the severity of symptoms. Then you start your physical examinations. You examine the part of the region affected, and then you order some laboratory tests. What are the tests? Blood counts, you see the total leukocyte count, you assess the ESR and CRP, these are the acute phase proteins, and also you get the blood culture. If you suspect osteomyelitis, you get the blood culture. And simultaneously, you get some radiological investigations. You start with the plain X-rays, then subsequently, if in doubt or in cases which are ambiguous, you get CT or MRI, now also the bone scan. And if you suspect there is an abscess, so you aspirate the abscess and send for culture examinations. So, in clinically, acute osteomyelitis, the symptoms are more severe, the presentations is acute and severe, and patients having the child has high fever with chills, they have severe bone pain, and in patients, in childs with lower limb involvement, they refuse to bear weight. Okay, they stop walking, or in upper limb, they stop using that arm. But in subacute form, it has an indolent course. They have a low grade fever, like occasional pain. The pain is not that severe, and very minimal systemic signs. Similarly, in chronic osteomyelitis also, you get these symptoms, very minimal symptoms, minimal signs, and the important features of chronic osteomyelitis is you get sinus, ulcer, the sequestrum. Okay. So, the symptoms are more severe in acute one, and gradually it becomes less severe with minimal symptoms in chronic form. So, physical examinations, if it is a lower limb or upper limb, you get to see the local temperature will be high, high to palpation. Always examine from the opposite side, always compare with the opposite side. Okay. There will be limb soiling, it would be severely tender to palpation. Okay. The tenderness would be localized to the region of the bone affected. It is most likely in the metaphysis. Okay. And always in child with osteomyelitis, always examine the nearby joint. Okay. Because you should not take the risk of missing the septic arthritis, because they have a high risk of spread of infection to the joint. So, you have to examine the joint for septic arthritis. So, in lower limb, they either patients, a child with walking age, they have a limp, or they can't bear weight on the limb. And in we get to see pseudo paralysis in infants. So, in very young child, if there is an upper limb involvement, they just keep the limb like this. So, it masquerade as a paralysis of the upper limb. So, this is also important sign that if you get a irritated child with systemic signs and symptoms and features of like that baby is not moving upper limb, it's like appears as a paralysis. So, keep in mind that it could be a septic arthritis or osteomyelitis. And important red flags, these are the danger signs. The patients having night pain or persistent fever, and who are responsive to the antibiotics, then you have to suspect that something is wrong and something is chronic. So osteomyelitis diagnosis, it's an emergency. Acute osteomyelitis, you should keep a high clinical suspicions. Even if you are like, based on the clinical suspicions, you can start your empirical treatment. Okay. So the presenting signs and symptoms vary. Okay. Even the high fever, chills, they could be less prominent in very young child. So you have to keep in mind, depending on the signs, symptoms and presentations, osteomyelitis in your differential diagnosis. And always, again, I am stressing the point, evaluate the joint for the evidence of septic arthritis. So the basic laboratory workup, you get the total leukocyte count, this is inflammation marker. In acute osteomyelitis, it is raised, but in subacute and chronic form, it could be minimally raised. So similarly, ESR CRP, they are raised in osteomyelitis, and they are very important for monitoring of the treatment, whether it is responsive to the treatment or not, because the CRP level falls within 48 to 72 hours. If the child is responsive to the treatment is working, then it starts falling after within 2 or 3 days. So you have to keep on checking CRP level after 2 or 3 days to see whether your treatment is effective or not. Similarly, you can get the blood culture, but blood culture sometimes they are negative. Okay, so you get positivity in 30 to 50% of the acute cases. Not all cases you get positive blood culture. So a negative blood culture doesn't mean that you don't have osteomyelitis. And finally, this is the bone biopsy. This is the gold standard for chronic osteomyelitis. So you get, you consider bone biopsy in chronic form. Now this is an important point. This is very important to understand. So once you order some X-rays, so depending on the nature, depending on the chronicity of the infection, depending on the duration of the symptoms, you get different X-ray pictures. Okay, so please keep in mind all the X-ray pictures, all the radiological features, and what are the excuse me, what are the reasons for this kind of, what are the basic pathogenesis for this kind of radiological changes. So initially, within 2 days, you only get to see local soft tissue swelling. So in X-ray, you see the local swelling, the normal fat planes, they are lost, but you don't get to see some typical features of osteomyelitis like bone destructions, periosteal reactions. They appear after 1 week, in 10 to 14 days. Okay. So once it progresses to the chronic form, subacute and chronic, then the bone destruction features and new bone formations, they are more prominent. Okay. So this is the earliest sign. This is within maybe less than 7 days in acute form. So see, there is in X-ray, this is the X-ray of the elbow, okay, in a very young child. So this appears as a soft tissue shadow. Okay, there is a fluid collections, inflammations. So this radio dense, a bit of dense compared to the surrounding. So this is the initial picture. Once it goes to the after 7 days, maybe 10 to 14 days, then the typical features of acute osteomyelitis, they appear. You get periosteal reactions. What is the reason for the periosteal reactions? Because the metaphyseal cortex breaks and the pus comes out, it elevates the periosteum, and the bone, this is the response to of the bone to contain the infection. So the periosteum react with the new bone formations. So this kind of periosteal reactions you see, irregular periosteal reactions and some lytic changes, some minimal changes of bone destructions. This typical features you get after 10 days. Then it goes to the subacute and chronic form. So gradually, if the child is not treated and the diagnosis is missed or it progresses to chronic form, then the more severe features of bone destructions. You see, almost it is a heterogeneous with bit of thickened endosteal sclerosis is present, periosteal reaction is present. And finally, in the chronic form, in 6 to 8 weeks, you get to see the typical features of chronic osteomyelitis. So, what are the typical features? The three names: the sequestrum. This is the infected foci. This is the radiodense sequestrum. The involucrum, the surrounding reactive bone, and the cloaca. This kind of hole. You don't get to see cloaca in every X-rays, but this openings in the involucrum. So what are the purpose of cloaca? Why do you see this kind of holes? For the drainage. Okay, so this is the infected foci in the bone. Surrounding tissues are involucrum, and in involucrum you get to see sometimes the cloaca, so that the the content of the bone, infected material, they drains out through these openings. So again, in chronic form, this is the radiodense sequestrum. This is the infected foci. Okay, the surrounding tissues, because the sequestra is the infected foci, the necrotic bone. So once this necrotic, in chronic form, you have to remove this necrotic bone, because this is the main source of infection. This is the main source of chronicity of the infections. This is avascular. So it is like very resistant to antibiotics. The surrounding reactive bone, this is the involucrum. This is radiodense. This is a new bone. Then in patients, if you suspect like your diagnosis is ambiguous, the features are ambiguous, then these are the advanced radiological features, radiological investigations you order. You order MRI. So MRI, there are the different sequence of MRI, T1, T2, and also some contrast MRI. So basic, you just remember the basic things. In T1 you get the fluid, the edema fluid, they appear as a low signal intensity, basically dark. So this is the T1 image. See, there is this part of bone is infected. Okay, there is a edema, inflammation is there. But in T1 it appears as dark. Whereas in T2 image or fat suppressed image, any kind of fluid, they appear as bright. See, this is the fat suppression and T2 image. So this area appears as a bright, inflammation is there. So in T1 it is dark and T2 is bright. It's simple, this basic concept. And in chronic osteomyelitis, this CT scan, they helps to identify the area of the bone affected. If you can't see the sequestrum in X-ray, then if you plan surgical interventions, then this CT scan helps you to identify where is the sequestrum is there, which part you need to remove and you have to access. Okay, so in CT scan it is clearly visible, this infected dense foci sequestrum, and also this is a quite dense involucrum. Okay, so this is the X-ray, radiological X-ray, and of the same patients, this is the CT scan. See, this is the axial CT scan. You see there is a very tiny radiodense foci is there. Okay, so this is the sequestrum. And also ultrasound, you can get to see, ultrasound helps you to detect subperiosteal collections in children, and also the bone scan. Okay, bone scans, they pick up the the area which are very active, very inflammation is there. So they pick up the radioactive material. So if the radiological features are not conclusive, very ambiguous, then MRI and bone scan, they helps you to diagnose osteomyelitis very early, because the radiological features, they appears quite late, after 10 days. So this differential diagnosis you have to keep in mind. So always keep high index of suspicions, because you can't afford to miss the diagnosis of osteomyelitis. Cellulitis, soft tissue abscess, septic arthritis, this could present along with septic osteomyelitis. Some bone tumors, these are the bone tumors, Ewing sarcoma, osteosarcoma, they often present with features of osteomyelitis. Sickle cell crisis, okay, they present with acute bone pain and inflammation, they appears as a osteomyelitis. And others, glycogen storage disease. Okay, so these are the differential diagnosis. Now management, once you diagnose the osteomyelitis and you think, okay, this is now you have to, how would you approach treatment? So to understand the concept, you need to remember these are the 5 basic principles. What are the principles? The NED, he was the scientist, he proposed that the number 1, the antibiotic is effective only before abscess formations. So that here lies the early detection of the osteomyelitis. So if there is a abscess formations and the starting, if you delay in starting the antibiotic, then the effectiveness decreases. So always suspect osteomyelitis, diagnose it and start the antibiotic as early as possible. So antibiotic do not sterilize avascular tissues and abscess, okay, because these tissues are avascular. So such areas require surgical removal. So once there is abscess, you need to drain it or either percutaneously or surgically. So once you drain the drain the abscess, then you can close the wound, okay, and then start the antibiotic. Since in any infected region, the region is quite, basically there is a ischemic changes are there. So when you plan surgery, do not damage the vascularity, do not be over aggressive, always handle the tissues very gently, because surgery should not damage the already ischemic bones and soft tissues. And antibiotics to be continued after surgery till CRP normalize. So even after surgery, you have to continue the antibiotic. So the surgery antibiotic, they are complementary. So in patients in acute osteomyelitis, you start the general supportive care with IV fluids. Analgesics is important to ease the baby, to give comfort to the baby, to the patients, and always keep the limb in comfortable positions. You can splint the limb to decrease the pain. If there is no abscess, start empirical IV antibiotics. It should be started as early as possible. Thus, how do you monitor the treatment? Get the CRP value, get the baseline CRP value, and after starting the treatment, get it done every 2 or 3 days and get the trend. If you see that CRP level is on the decreasing trend, then you are sure you should be, it should give you comfort that your treatment is effective and that the baby or the child will recover. If there is no response to the antibiotic treatment after 2 days, then what could be the reasons? The reasons could be either it could be that your antibiotic is not responsive, means that the organisms you are suspecting, they are resistant to the antibiotic, or there is an abscess formation already has happened. So if there is abscess formation, you have to drain it. So that needs drainage. So these are 2 main indications for surgery. What are the indications? If there is abscess formations and the patient doesn't respond to antibiotics. This is a very simple flowchart to help you understand. If you suspect osteomyelitis, but always importantly, do not rely on the lab investigations or x-rays. Always physical examinations, history is very important, because sometimes you have to start treatment based on your clinical suspicions, because lab investigations or x-ray features, they are not always very pathognomonic for the osteomyelitis. So after you suspect osteomyelitis, get the lab test, blood cultures, you get the x-ray features, and you can start the treatment. But in equivocal cases, if your radiological features, lab tests are not conclusive, then you go for the MRI. And also, if you suspect that is the abscess formation is there, you can aspirate the abscess, you can aspirate the region and send for biopsy or culture investigations. Then you start the empirical antibiotic, and based on the culture report, you change your antibiotics. And you monitor your treatment with serial assessment of the CRP level every 2 or 3 days. And despite all this, if treatment is non-responsive, treatment is not effective, then you have to plan your surgical treatment. This is antibiotic. What are the antibiotics? Which are the commonly used antibiotics against these organisms? So like you know better than me, the pharmacological part. So in group B, Streptococcus, gram-negative, ampicillin, gentamicins. If there is a Staph aureus, okay, so this is the basically antibiotic related. So you can like get the chart and take the picture. So what could be the complications if your acute osteomyelitis failed to respond to treatment, or the treatment is delayed or neglected? It could progress to chronic osteomyelitis. It could be septic arthritis, and it is a very devastating complication. Septic arthritis can damage the joint permanently. So similarly, septic arthritis or osteomyelitis, since it is near the growing region of the bone, it can lead to growth disturbance. Okay, growth, that means it could be lead to angular deformities could be there in future, or the growth could be stunted, and it could lead to septicemia, DVT. DVT is deep vein thrombosis, and pulmonary embolism. So now subacute form. Subacute form, as I told previously, it is like these are caused by the low virulent organisms. So the symptoms and signs are very minimal. It is unlike acute osteomyelitis, it has a very indolent course. Okay. Similarly, based on the clinical features, you have to get the X-ray radiographs for the diagnosis, and since the clinical signs and symptoms are very minimal, so very often you have to go for the MRI to narrow down your diagnosis. Okay, diagnosis is sometimes established with biopsy, but biopsy is even not confirmatory because in most of the cases you get negative biopsy. This special kind of subacute form, Brody abscess. Okay, this is a kind of subacute osteomyelitis. They affect the the end of the long bone, the metaphysis, caused by the low virulence organisms, very minimal signs and symptoms, indolent course is there. So in radiology, you get to see the osteolytic foci surrounded by a sclerotic rim. So this is the typical features of a Brody abscess. Okay. So if in doubt, you go for the MRI, and the treatment is you have to drain out the infected region followed by the antibiotic. The typical features of Brody abscess. You see the growing region is affected in the metaphysis. So there is a schematic diagram. This is the kind of infected foci. It is surrounded by a reactive region of the bone, that is sclerotic rim. What is this? This is a T1 image. Okay, because it is the fluid is appearing as a dark, and this is a T2 image. The fluid appears, the inflamed region appears as a bright. So this is a typical radiological and MRI features of a Brody abscess. Now in chronic form, the chronic form is the hallmark. The most important features is there is an infected foci inside the bone, and the surrounding tissues are really compromised. It could be a defect in the surrounding tissues. They are maybe compromised in a blood supply. They could be ischemic. So these are the main features of chronic form. So this sclerotic foci, it is surrounded by a relatively ischemic or scarred soft tissues and avascular thick periosteum and bone. So they basically seal off this area from the blood supply. So the antibiotic alone is not effective. They don't reach this area in sufficient concentrations to neutralize this infection. So see, this is the sequestrum. This is the infected foci, and involucrum, this is surrounding tissues, the surrounding reactive bone formations. This involucrum is often have a perforations opening. There is a cloaca. Charney mother classification is there for the chronic osteomyelitis, but it's very complicated. It's not for you. So diagnosis, and come to the diagnosis and management part. So in diagnosis, based on you have to get the clinical features, symptoms, signs, and clinical examinations. You get to see what are the features. You get ulcers, you get this draining sinus. There could be deformity, and overlying tissues could be necrotic, damaged, or scarred. So, in chronic osteomyelitis, the main form of mainstay of treatment is the surgical removal of the infected foci and followed by the biopsy. Following the surgical removal, you have to start the antibiotics, and also after removal of the necrotic foci, you have to do some kind of reconstructions. So, this was the tibial osteomyelitis. Okay. After removing the infected regions, what we did, we put some, this is a whitish dots you see, these are the PMMA beads, polymethyl methacrylate cement beads. Okay. So, they have antibiotic beads. We have mixed the antibiotics in the cement beads, we can put inside the region. So, they deliver the cement in high concentrations to this infected region. Okay. So, these are really effective, and this is the vacuum assisted closure, vac, because often you get, because the overlying tissues is scarred, necrotic, very often you get after removing the damaged portions, there is a huge defect to the soft tissues, but you have to close the soft tissues, because without, if there is a continuity, if there is exposing the, if the underlying bone is exposed to the environment, the infections won't heal. So, this is the newer modality of treatment. So, vacuum assisted closure, it continuously suck out the content, infected material, and also close the gap. So, these are the overall basic clinical approach and basic concepts of acute and chronic osteomyelitis. Before I finish, so there are the 2 or 3 couple of cases. So, just try to focus, and you have to answer the, you have to apply your brain. So, the first one is, this is a 10-year-old boy. He has the symptoms of 5 to 6 to 7 days of fever and also pain on the thigh and hip region. He is walking with a limp. In examinations, you get high temperature. The region of the thigh is tended to palpations. There is a swelling, and he is refusing to bear weight. Okay. In lab, you get all the values are high. TLC, ESR, CRP, they are quite very high. You even get the blood culture, it comes positive for the Staph aureus. So, what could be the diagnosis? Acute osteomyelitis of the thigh. So, what are the imaging features? Now, in imaging, you order the X-ray. What features you get to see? What do you think that after 7 days, what features you think that you can see in the image? X-ray. Abscess is not visible in X-ray. Yeah, after 7 days, you get some kind of lucency, periosteal reactions. So, lucency is there, and then see thin periosteal reactions. Okay, the changes starts appearing after 7 days, and then I get the MRI. MRI we get metaphyseal abscess and subperiosteal collection is there. Now, what do you think? The treatment? Antibiotic. Anything more? Exactly. So, this is the catch, because it has abscess. So, once the abscess forms, you have to drain it. You continue the antibiotic. So, this abscess formation is there. So, IV antibiotic and surgical drainage. These are complementary. You have to do it simultaneously. And after treatment, after you drain the abscess, what happens? The CRP normalizes by 10 days, but you have to continue the antibiotic for 4 to 6 weeks. Maybe IV antibiotics. So, there is a different protocol for antibiotics, but in general you can continue the IV antibiotic for 2 weeks followed by oral antibiotics. Case number 2, this is the adult patient, 45-year male. He had an open tibia fracture. Open means the tibia fracture, and that was exposed to the, that is called open, because previously we used to call it compound. It is not compound, it is open fracture. So, 1 year duration, then subsequently developed sinus and pain. On examinations, you get first discharge from the sinus, local temperatures are raised, and there is a local signs of inflammation is present. ESS, CRP are high, but not that high. Yeah, it is definitely high. WBC level is, unlike acute form, it is not, it is quite normal, and in culture you get MRSA. This is very dangerous. So, in X-ray, What do you plan to see? What is this? What is that? Yeah, this is a chronic osteomyelitis. So, the tibia, see, all the features of a chronic form is present. And then management. How do you plan? Only antibiotic or anything more? Yeah, that is sequestrectomy. The debridement and sequestrectomy. So, sequestrectomy, we put the beads, we can put the vancomycin beads, cement beads, and since the soft tissue coverage was very precarious, we have to close it with a muscle flap coverage. Okay, these are the beads and then coverage and followed by the antibiotics for 4 to 6 weeks. And case 3, this is not that interesting. This is a diabetic foot. The patients having diabetes mellitus, there is a foot ulcer. Serous discharge was present. In X-ray, you see bone destructions and features of cortical erosions. So, this is a diabetic ulcer, diabetic osteomyelitis. So, since there is abscess formation, we have to drain it, followed by the debridement and antibiotic treatment and control of the diabetes mellitus. So, the first and foremost, high clinical suspicions, early diagnosis and treatment. Okay, because chronic osteomyelitis is both acute and chronic, they are very devastating for the child and for you also. Chronic osteomyelitis is very difficult to treat. So, early diagnosis and treatment is very important. And in patients who are not responsive to treatment, if it is a chronic osteomyelitis or if there is abscess formations, you have to combine your surgical debridement with antibiotics. Monitor your treatment with the CRP level and involve the multidisciplinary team of infectious disease specialists who can give you advice about the antibiotics, team of plastic surgeons who can help you to plan the coverage of the wound,